low-speed motor vehicle collision. This patient showed up at an outpatient clinic in Winston-Salem, North Carolina, if you were wondering. Just to introduce a little bit about what this whole purpose is, I'm going to describe a case of a patient with chronic low back pain. I'm going to try to examine some research as it relates to this case. And I'll try to identify some potentially beneficial measures and treatment modifications that I would have done if I had researched a little bit previous to the case. So a little bit on the patient. She's a 33-year-old female. She's married with 2 children, ages 2 to 4. She's Hispanic, which only really matters because English is her secondary language, so she did require an interpreter. Interesting thing though, the interpreter showed up about a third of the time, so that was pretty fun. She works at a car wash facility, which is where she was injured, so this is a workers' compensation case. And she had no previous injury history or significant medical history or medications, basically clean bill of health prior to her injury. She was injured at work on March 14th, 2016, and that's about pretty much everything that's happened to her since then is going to be reviewed in just a second. So some previous treatments. She got MRIs at her lumbar and knee. The MRIs were done about 2 months after the fact, after she already had some PT. They had no significant findings for either place. At that point, she still wasn't getting any better with PT. She started getting PT about the day or two after she was initially injured at my facility with my CI. And she basically said from March to November, through all that PT, she really wasn't getting a whole lot better. So after talking over with my CI, we decided that I would just kind of go in blind, so to speak, so I wouldn't be biased by anything that he had already done. So already, just knowing that stuff after talking to her for a couple minutes, here's some of my thoughts. Going off the Toledo classification system, she falls under chronic just based off the timeline of being more than 3 months of pain. She did have some ridiculous symptoms, but that's not really something that you guys know yet, but I do. Some other ideas that I came up with just because the chronic pain thing isn't all that helpful for me right now. Repeated motions is always there. Just when you have ridiculous symptoms, thought it was a possibility. Knowing my CI was McKenzie certified, I figured you probably would have done that. So I kind of moved that off to the side for a little bit. So that's why that's crossed out on the slide. My other 4 options there were lumbar instability, some SI joint dysfunction. Knowing how she got injured, she got hit on her hip, which I'll go over in a second. And some hypermobility perhaps as well, considering she had children, she's still pretty young. Manipulation was also on the table. I didn't think it was that likely just because of how she was injured, but I'll describe that. So the way she was injured, she works on the car wash and she cleans cars by hand. The cars are on a belt and they'll be pushed forward once they're done. So she was working at the front of a car, cleaning it, bent over with the car on the left side, and the car behind the one she was working on was pushed forward on the belt too early, and it bumped the car she was working on, and then the car hit her right on the left side of her pelvis. So that is why I thought SI joint dysfunction was possible, just because you have that direct load of the pelvis. So that's where that idea came from. Going into her pain history a little bit, you can see she has pain in the lumbar spine, left hip, and left knee. You can see all the numbers there, but basically lumbar spine pain is pretty high. It's probably the worst thing she's reporting right now, and that's her primary complaint when she came to me. The left hip was also there, but that was pretty much a referral pattern down the left lateral thigh. And her left knee pain was basically focused on the left medial knee, kind of unrelated to the lumbar pain for the most part. But if we go into the symptom behavior, you can see a little bit more clearly. Lumbar symptoms tended to worsen with a lot of bending or prolonged positioning, either sitting or standing. She couldn't really do a lot of walking because of pain. Laying supine or prone for anything more than about 15 or 20 minutes was also really bothersome for her, so she had to sleep on her sides, typically her right side, because that was the least bothersome. Also, transfers sitting to or from standing were very painful as well. The only thing that really helped her lumbar pain decrease after it got worse than that 4 was just resting in a different position than what she was. So if she was standing for a while, sitting down, once she got into a sitting position, that would help relieve her symptoms. Hip pain tended to worsen with her lumbar pain. So if she bent over, she'd feel pain running down her hip. If she wasn't bending over, typically she didn't feel any pain in her hip. The knee pain was a little bit different, didn't behave along with lumbar or hip pain. It tended to worsen with weight bearing, transfers, or active knee movement. Open or closed chain didn't really matter. The only thing that really helped reduce that knee pain back down to that 0 level was just basically sitting with her foot supported or unsupported. So that kind of helped roll in or roll out ligaments as far as me going into testing. Just some observations that I noticed with her sitting there talking to me. She tended to sit with her trunk flexed, and she was kind of resting on her hands. So not obviously the best posture, but seemed to be comfortable for her since she was that way through basically the whole examination until I got her moving around. As far as her gait goes, I'll have to demonstrate this. I guess over here, she ambulated with a lot of excess left hip flexion, so it seemed to help with foot clearance, not because she had foot drop, but she did have foot drag, so maybe a little bit of weakness on the dorsiflexion is what I'm thinking there, but who knows at this moment. She could have neurological weakness, could be a muscular thing, I'm not sure just because of the time frame, but it kind of looked like this, when she would really clear it. I know you guys can see this, so I'll walk over there really quickly. So it was pretty similar to kind of this motion here. So did you see it, Dr. Smith?
Yeah, I did.
I can do it again all day. So when we get to the examination, I checked her back first, just because that seemed to be the easiest thing to check. You can see her range of motion there is in percentage, not degrees. Don't freak out, she's not that mobile. Everything was painful, all motions. Strength was tested with her in sitting. I learned this strength testing at one of my previous internships. The way they do it is with you sitting, you push on their shoulders and just check to see how much resistance they can give. So that's where that strength testing comes from. That wasn't taught here. So yeah, that's pretty much all that was there for the lumbar motion and strength testing. There is some aberrant motion present with flexion, both on the concentric and eccentric part. So that's starting to lead me more towards the instability category a little bit. So that's just something I'm thinking as we go along. Continuing on, if you look at the lower extremities a little bit, you can see hip flexion was pretty weak all the way down, basically from hip flexion to ankles, especially on the left side, a lot of weakness, a lot of pain with different movements, especially at the hip and knee. Ankles were generally okay, but you can see on that left side, you have that really weak dorsiflexion as well. So pretty much nothing all that interesting there, or at least nothing all that surprising. Going into some range of motion, at the hip at least, you can see that she was pretty limited with hip flexion, and that was mostly due to pain. I could not get her to go any further because she asked me to stop. I didn't want to really force the issue because she was basically yelling at me at this point, so I didn't want to really go too much further. And this was regardless of whether her knee was bent or straight, so it didn't really make a difference there for hamstring length. But you can see that hip flexion is definitely really limited, so that's a positive sign of the buttock at least. I definitely think there was more there, but it was just really guarded, and all that pain was really preventing me from going any further. The rest of the lower extremity was pretty much within normal limits as far as I can tell. This was what I could check. I didn't really check rotation just because I would usually do it in supine rotating there, but keeping her at 90 degrees wasn't really going to go very well for her. So I just kind of left it at that. You can also see myotomes, dermatomes, reflexes are all pretty good. The only thing that I saw that was a little bit different from neurological screening was there's some extinction present on the left side when I was checking on the right as well. So pretty much nothing neurologically showing up that I was able to pick up on. We go into some special testing. You can see the slump test was not positive, so that's good. Straight leg raise was painful on both sides in her lower back, not anywhere else. Sacral distraction and thrust were both positive, so she already meets the criteria for SI joint dysfunction. The reason why I kept doing the sacral compression test was just because of how painful she already was. It was kind of difficult to know if what I was doing was actually causing her pain or something else. Going through the interpreter with her was kind of difficult to figure out what exactly she was saying, so that's why I did the compression test as well, just to try to confirm what I was thinking. She also had a leg length discrepancy of about 1 inch or more on that left side, so pretty significant there. So at this point, I'm definitely going down that SI joint pathway. Also did some knee testing just to check out what's going on with the knee. She was not really clear on how she described her symptoms when I did any testing. I checked varus valgus, Apley's, Thessaly, tried to do all those for meniscus and medial ligaments, and nothing really came out pretty clear for me there either. So knee's a little bit of an ambiguous area for me right now as far as what's going on with her, but I figured if I could at least focus on her back pain, I could try to help with that first since I have a better idea of what's going on there. You can see our Oswestry score at the bottom is 46, so not great, not terrible, but definitely could be a lot better. As far as palpation goes, you can see there's a lot of tenderness basically everywhere down the left leg. You point to a spot, it's probably tender, so no real surprises there as far as anything up there on the screen goes. Couple interesting things are the pain on the SI joint along the joint line, PSIS, Fortin's points, those were all pretty tender as well. So again, still thinking SI joint at this point more than anything else. The tenderness on her lumbar spine globally was just really bad. I basically couldn't do any sort of joint mobilization or joint mobility testing just because just trying to sink in even past her superficial tissues was really aggravating for her. And also laying in prone for that long period of time was going to aggravate her a lot too. So it was being too nice, but I was just trying to spare a little bit so I could get to some more valuable information. One thing I did notice was muscle atrophy on the left paraspinals compared to the right. I'm just calling it atrophy, but it could just be the right side stronger. Again, I'm just going off the timeline. It's hard to say, but it would make sense that since she's been injured for about a year at this point, that she probably did have some muscle wasting on the left side. So just to kind of summarize a little bit from the exam, because I know there's a lot up there, she was positive for sacral distraction, sacral thrust, and she had leg length discrepancy. All those things tend to correlate pretty well with SI joint dysfunction. So that's kind of top of my list there. She was positive for aberrant motion, and she had age less than 40, which is 1/2 of the cluster for lumbar instability, although it's kind of the weaker ones if I was to guess. But thought about the prone instability test. Again, how much pain she was having. I didn't think she would tolerate me pressing on her back and then having her do that leg extension. So I kept that in the back of my mind, but I didn't want to do any more testing with that either. You can see left lower extremity is really weak. That's about all there is to that. And she's really highly reactive with any lumbar or highly reactive lumbar hip pain with any sort of movements, specifically flexion moments, external flexion moments. So, and it also works with prolonged static positioning, which also helps support that lumbar instability cluster. So a lot of things going on. Any questions so far?
The straight leg raise test.
She was positioned supine, the opposite leg was bent. So if I tested her right leg, left knee was bent, and I would just have her raise it actively. I tried supporting her as well, and that was painful either way.
Did you provide any external?
I didn't, and I should have, but at that point I wasn't thinking SI joint. Okay. So.
Was the interpreter there for this visit?
Yeah, the initial evaluation, they were there. Yeah. So, any other questions? All right, I'm going to go ahead and move along. So if you break it down with the ICF model, you can see I gave her the health condition of SI joint dysfunction and lumbar instability since she does meet those clusters. I thought that made some good sense there. Impairments, basically lumbar pain with radiculopathy, all the weakness, leg length discrepancy, and basically everything else there I talked about. You can see all of her activities there. Those are things that I discussed with her that she thought was important for her to get back to her normal life. So that's why I think just like walking and sitting are there, because if she said if she could do those, she could go back to her job without a big problem. You can see she's a caretaker for her children and her husband. Not that he's disabled or anything, but you know how guys are. They take care of us. So that's just how it goes. Environmental factors, car wash facility is pretty flat from what I got described to me. So not any hills or stairs, anything in that facility. So that was pretty clean. So I wouldn't have to worry about elevation that much. And same thing with her house, single level home, or she had access to an elevator. So again, didn't have to worry about stairs that much. So that was good. Personal factors, obviously mother of 2 children. Again, that kind of helps, especially with how recent the children were. That again gives you some support for SI joint. She's a wife, 33, so pretty young. But basically the big one I want to focus on is the English as a secondary language, because from here on, getting that interpreter to show up was really difficult. So that's an issue for sure. So if we go into the treatment plan, I kind of had to write this based off of what we were given by workers' comp. They gave us 10 visits, so we broke it down, talking to her with how often we will see her. Since she's still working but on restrictions, we kind of made it about so we could do about 2 times a week, but possibility of 3 times a week occasionally. So I did 2 and 3 times a week for 4 weeks because the math checks out there. If I were to do it on my own without having to worry about visits, I would have asked for closer to 8 weeks, considering the chronicity of her pain and how long she's had it. So that's where my mind is there, but my expectations were just to try to centralize her symptoms or minimize her symptoms as I could, and just increase her ability to sit, stand, walk. All those just general ADL movements without increasing your symptoms. So some goals, aside from the obvious increased strength, range of motion, and all those, were just to sit and stand for at least an hour without increased pain. I wanted her to be able to walk for at least an hour without increased pain. And obviously, since it is workers' compensation, you do want them to return to work without any restrictions. So that's why that's also on there too. So if we get to the treatment, this is just a big list, all kind of divided up on a timeline in a second, but just so we can go over these really quickly. The first thing I did day one was an MET for pelvic downslip, the superior shotgun technique. For those of you who don't know, for her, since we were thinking it was a left downslip, you would do isometric left hip extension and isometric right hip flexion at the same time. So you'd bar their leg with your arm between their legs, and they would try to basically break your arm, for lack of a better phrase. So the idea there is just to try to use her muscle energy, that's why it's called a muscle energy technique, to basically reposition the pelvis. Also gave her some stability exercises that day just to try to create some muscular stability around the joint, maybe help reduce her pain a little bit too, just by causing some muscle activation. And that was basically day one. But going on down the line, later on, we gave her an SIJ belt, hip knee strengthening exercises, education, modalities, lumbar and thoracic joint mobilizations, soft tissue mobilizations, and we eventually tried repeated motions with her as well. But here's what it looks like. It's a timeline. So I mentioned day one. We had to do the MET pretty frequently with her at the start because every time she'd come in, she would have a lot of pain. She would have that leg discrepancy again. And I wasn't trying to focus on that structural abnormality, but it did seem to correlate with her pain pretty closely. So I did do that MET repeatedly, usually at the start of the session. We would follow it up afterwards to see how she felt. Usually after a couple minutes, she would feel a lot better as far as her symptoms go, and she could walk a little bit better. But that might have just been me hoping that she walked better. We'd always do stability exercises with her every single time. Let me go over the water first. For the education part, a lot of what I was trying to focus on was that she's not broken. She had a lot of fear about bending. Every time she would bend over, she had a lot of pain. She was really fearful of trying to move too much, especially in ways that would hurt her, because she would report a pop in her back. And whenever that happened, she was really concerned about that being a bad thing. So my education for the first couple of days was just trying to get her to calm down about that and say it's not necessarily a bad thing. Popping happens, and I would crack my knuckles in front of her and show her it's fine. So she didn't seem to, she didn't have as much problems with that after a while. Next couple visits, we did some more hip and knee strengthening as her symptoms started to get a little better, but we still had to do the MET pretty frequently. So I came up with the idea of giving her an SIJ belt, and she ended up buying one on her own. It was pretty cheap. It was like $20 on Amazon. Workers' comp wasn't going to approve it very quickly. So she agreed to pay that, and when she got it and she wore it to work and everything, she actually said it felt a lot better. So that was probably one of the best interventions that she had as far as giving her immediate relief, was just that support. So at that point I was definitely thinking SI joint problem, and she still has a lot of weaknesses and instability. So that helped kind of confirm what I was thinking too. Moving on to visit 6 and 8, we did kind of progress with our stability exercises, hip and knee strengthening, and I tried repeated motions, and at this point I wish I hadn't, because the very first time we tried to have her extend, she felt a pop in her low back, and she had immediate spike in pain, and we weren't able to get it back down. And after that point, she really wasn't able to get back down to where she was on visits like 4 to 6. So I think I jumped on that a little bit too early, but she definitely did meet a lot of the requirements for repeated motions, just because of her complaints of flexion being painful. Extending usually wasn't painful, but that was just my error there. Visits 9 to 10, when she came back, we're mostly focusing on trying to get her pain back down. So I did some more soft tissue stuff. I was able to get into joint mobilizations a little bit. But that took a while. So I usually do that at the start. Sometimes we did modalities. If I wasn't available at the time, they would usually put her up on either heater stem or both. And usually that could help calm her down before I got started with her as well. And then she had a little bit of a layoff because workers' compensation isn't always the fastest at approving more visits. So she had about a month plus off from when I did a progress note on her to when I saw her again. So that's where that following the break thing comes in. So visits, I should say 11 to 14, We started doing a little bit of other stuff because her symptoms were pretty much the same. So I figured what I was doing before wasn't working. I should probably start trying something different. So tried a little bit different stability exercises and went more into the soft tissue stuff because that did seem to help her a lot when she was there last time. Just didn't last very long. And then we focused more on the hip and knee strengthening again to try to build up that lower quarter strength. So for home exercise program from day one was the stabilization exercises, and we would progress those as she went along as much as we could. We eventually instructed her on that superior shotgun technique so that she could do it with her husband if she needed to, because we trusted her to know what it felt like. She was pretty intuitive about how her body was moving. And then eventually we also gave her the SIJ brace, which I already mentioned. So at follow-up, which was about visit 10, you can see her osmometry score was unchanged, so that's hurt my feelings, but we'll kind of see what else is going on. You can see her pain didn't change a ton. If you remember, it's usually about pretty much that. The only thing that really did change was her lumbar spine pain. The best score was a lot lower, and she said she was usually about that 2 to 3 range as opposed to being at that 5 or 6 that she usually was at before, which I thought was pretty good. Just so happened the day she came in, she had worked the previous day, and she was pretty sore from that. So that's where that was. But overall, she was saying she was feeling better in general, but not quite 100% yet. The knee pain was completely unchanged. At this point, I'm still not really sure what's going on with that because of the imaging. And then basically notes from her doctor weren't all that helpful at laying in her out things there either. So knee pain is not changing, but the hip and the back pain are changing, so at least that's good. You can see some strength improvements, not a lot, and the things that did improve didn't improve that much. So also not great so far, not getting too hopeful yet, but that's basically what it is. Sometimes you have that, sometimes you don't. You can see hip flexion, ankle plantar flexion changed just a little bit. So anything else that's not up there did not change at all. When we go into her functional activities, though, she's reporting that she can walk, sit, stand for a lot longer, up to 6 or 7 hours, which is basically her work shift, without increasing her pain. She's still not painless, but it's not getting worse. So that's definitely good. And that's regardless of whether she's wearing the belt or not, but her pain's lower when she does wear the belt. So again, I'm still thinking that instability cluster is still relevant here. But she still had a lot of continued limitations with bending activities or anything with that external flexion moment. So that's where I'm still thinking she's a repeated motions candidate. But by the time we did get her back, her symptoms hadn't changed enough where he felt comfortable enough going back into those repeated extensions again. So some of my thoughts, if I could go back from day one and redo some things, some sort of fear avoidance or psychosocial factor measure would have been really good for her. I'm thinking FABQ sounds pretty good, but that's kind of, you could do several, but that's probably my favorite one for someone like her, considering how our discussions went. Functional testing is something that I would have rather done more of, but considering how her functional activities went, is usually for a longer period of time. Even day one, her complaints were usually activities like sitting or standing for like 15 or 20 minutes. I didn't want to just have her sit for 15 or 20 minutes and just measure that. So I didn't really have any good ideas of what to measure there, so maybe that could be a discussion we have in the room. The interpreters and language barriers was obviously a big thing because I don't know Spanish at all. I'm from West Virginia, so it's likely that I know English. So having conversations with her was pretty easy overall because she knew a pretty good amount of English. She could get by most days without an interpreter. But if she needed to describe her symptoms, especially if I was doing manual treatments to her, it was really difficult and frustrating for her to describe what was going on with her because she just didn't know what to say. And it didn't matter how I could ask the questions, or at least I couldn't think of a way to ask the questions where she could describe what was going on. So it was really frustrating for both of us that the interpreter wasn't always there. But the other thing was when the interpreters did show up, it was always a different interpreter. So there was no continuity there, and I couldn't build a relationship with any of them or as a group of 3 that we could really work together and figure out what was going on either. So I researched that a little bit, and surprise, surprise, having the same interpreter or a more certified interpreter who's always there leads to better outcomes. So maybe that's something that could have happened, but that's not really on me necessarily. So maybe I dodged a bullet there. Lastly, I probably had a little bit too much exercise variety because I tended to jump around a little bit too early, at least I think. Especially when she came back, I was a little bit desperate to try to get some better outcomes on her, especially with her symptoms and stuff. So I would try different manual techniques pretty much day by day. And I think if I had stuck with the same stuff more often, maybe I would have gotten better results. Maybe sticking to my guns a little bit more, or even just staying with just the stability exercises as opposed to going to manual treatments at all. But that's something that we could obviously discuss. But that's something that I thought I could have probably done better, was because I just wasn't super confident with what I was doing with her based on her lack of improvement. So those are all my references, and I will open the floor for questions. Have at it. You've been waiting all year. Yes.
My question was, I mentioned that your CI was certified.
Yeah.
And your additional hypothesis compound repeated motion. Was that something that you hypothesis, but then later on it's one of your top hypotheses?
Oh, okay. Yeah. So what I was doing there was just from talking to her, like just getting the baseline information, like how everything happened. I was just putting a list of what I thought were possibilities as far as like guiding the treatment. Since I knew he was McKinsey certified, I know he would have done repeated motions with her because that's basically how he treated most people. So I knew that he'd already done that and it didn't work. So I had that as an idea because she did have radicular symptoms, but I knew that since he'd already done it, it probably wasn't going to work if I did it again, especially since I'm not certified and I didn't know as much as he did about that topic. So that's why I had that crossed off. I came back to it just because I thought that eventually we could progress her towards that, but I wasn't sure when we would get there. Does that answer your question?
Yeah.
Mostly just prone extensions to start, maybe prone on elbows, but her laying prone for like 10 minutes was usually enough to cause her a lot of pain. So if I did manual treatments to her, once she would get up, she would have a lot of pain just from laying prone.
Is there something in her subjective, that you saw objectively that led to prone for primary treatment that you might?
Oh, I would pick prone first just because they're more supported as opposed to doing something like standing extensions or even against a wall or any other extension treatment. I usually stick with prone first just because they are supported throughout the trunk. That's my justification there. Does that answer no?
You also mentioned centralization, where you looked to centralize her hip symptom. That was related
Yes.
to lumbar
Yes.
joints as well.
So when you did extension, her pain got worse. Where did her pain increase? What was the location?
Right at her left SI joint. So I'm not sure if that was that downslip happening again or if it was anything else, but it's kind of hard for me to know without being able to see it. But all of our MRI images from before were negative, so it's hard to say if it was like a disc herniating or anything.
Go back to the MRI. Second.
Sure.
Where were her symptoms before you put her in prone and had her extend? What was her symptom report prior to that?
Oh, you're talking about like how far down her hip?
Where were her symptoms?
Typically, they were always focused at that left side SI joint and some like partly down to her buttock. Typically, if she would be bent over at all, it would go down into her hip. So if she was sitting, it would be down into her left hip, about over here, about midway down her thigh, and then the knee pain was there. So there wasn't any connection between the two. But when she was prone, she would still have that left hip pain as well.
So do you think she's centralized?
No, not when I was working with her.
So what does the MRI have to do with your decision making?
If there was some sort of structural damage, I would want to avoid some stuff, but I just put that out there just because it is good to know that there's not any structural damage.
So what sort of structural damage would cause you to avert from doing anything?
I guess really nothing, just because you want to go off how they actually present with impairments. But if she did have a spondy, maybe that could at least guide you to know that maybe she would be more flexion or extension oriented. Or if she had a herniated disc at a particular level, I would know maybe that's where I could look for certain symptoms as far as muscle weakness. So it was more of just something I use as like a tip to know like maybe I should check this or not check this more often. So that's where I was going with that.
didn't get that from the initial mention of the MRI, so I appreciate that.
Yes.
When you did your mobilizations, Pat, where did you do them and how did you?
So the lumbar mobilizations, soft tissue or spinal?
I don't know. What did you do?
Both.
So both. So let's go with, so you did joint mobilizations?
Yes.
So where did you do those and how did you?
Typically, I did bilateral because pressure directly to the spine's process was really painful for her, so I just did bilateral because that was a little bit more tolerable for her. I usually had to work her up with soft tissue first, just to calm her down before I could even do the joint mobilizations, and that was usually just oscillations across or parallel with the paraspinals.
Let's say what grade mobilization?
I was not able to get up to 3. Usually I could get 2 with a little bit extra, but anything beyond that was not really possible.
Did you feel like she was hypomobile?
Not really, no. Especially the lower lumbar, but upper lumbar was a little bit more mobile. So I thought that was interesting, but I'm not really sure how that would relate to her symptoms much. But thoracic, I usually just did bilateral, and she was pretty tolerable with those. So sometimes I would work her up with those first and just kind of work my way down, kind of to decentralize her or desensitize her a little bit. That was something else that worked usually pretty well for the symptom reduction. Didn't really help her with her function that much.
Is that what your goal was? Working on improved mobility or decrease pain?
Mostly pain first, like when we did exercise her, she wouldn't have as high symptoms because a lot of times she was really irritable with her exercises. Because a lot of things I did work with was with her on a stability ball, and sitting on the ball wasn't usually all that aggravating for her, but getting her on and off it was. And if I did manual first, I realized that she had a lot less problems getting, she had less problems with transfers, to say it that way. Yes.
Nice job. You did a nice job identifying you're using lilacs to identify that the SI was the source of the pain. I wrestle with, frankness, with an upslip.
Yeah.
So as you treated that, what was the purpose of you treating that?
Oh, I thought it was a downslip, just
Now, okay.
but yeah.
I equally struggle.
Yeah. Either way. The only reason I looked at it that closely was because it seemed to pretty directly correlate to her pain. I've seen it at previous clinicals, so this is more of just a thing that I've learned from my other CIs that they said has helped. So I thought after talking with my CI there, we decided that it's based on how long he had seen her previously, we thought it'd be something worth trying. And when we did it, she did have a lot of relief. So that was good.
So you mean that shotgun technique?
Yeah.
That's not what I struggle with.
Right.
So we got to be real careful that when we find something that works, we try to say this is why it worked.
Right.
And so based upon the evidence now, structurally positioned SIs, I don't think there's any validity to that.
Right. And I don't know if that's even what was actually happening.
And what I think I was hearing you say was relate that to the 1 inch difference.
Yeah.
That's what I was hearing. Let's just pause for a second and think logically. If that was indeed moving an inch, how unstable or fractured is that?
Pretty bad.
Yeah,
Yeah.
it would be. So most of the anomalies we see when we palpate are probably just that, anomalies, not indicative. Right? So the question would be, so the shotgun's fine.
Yeah.
It worked, that's great. Let's run with that, right? So the other thing would be, okay, so did you measure, do a mobility test to see if it glided up or glided down or that?
No, what I did to measure was just assessing at her ankle. So that was the only measure I did, but I didn't actually get a tape measure out and do that. So it's more just lining it up. Because before, if I put her ankles together, you could see that left malleolus was an inch distal. Whereas if I followed up with the MET afterwards, they were level. So that was my assessment for that. If that answers your question.
Raises many more,
Okay.
but I'll let Dr. Austin step in.
How did that correlate with her symptoms, with her presentation? So structurally she changed. Did you follow that up with an assessment, whether it was changing motion, changing symptoms, finding?
Yeah. So
You could, because now you're sort of, we're taking a couple of steps away from something. So I want to see how you mentioned correlated with her presentation. How did it correlate so strongly with the presentation?
Yeah, so my idea there was after we did that, I would ask her first of all how she felt. Usually immediately after she did not feel a lot better, but a couple minutes afterwards she would start to notice that a lot of her lumbar pain especially was less. And then after we would do some stabilization exercises like isometrics around the hip immediately afterwards just to try to activate those muscles again. And then we have her walk, and usually she would feel better walking than when she came in. So that was my assessment of that functionally as well. But I didn't do anything that would be measurable for that, which is what I identified as a limitation with what I did.
Overall, her pain decrease.
Yes.
How much did it decrease?
Usually she would come in about 5 or 6, and after that it'd be between a 3 or 2 to 4.
I think we're running out of time, so thank you, Pat.
Okay.
Since one.